started. And so before my usual COVID announcement, I just wanted to make the point, in case anyone missed it, that yesterday was the second anniversary of the original governor's stay-at-home order. So it was exactly 2 years ago today that we all went home for the first time for COVID. This meeting is being held remotely due to the ongoing COVID-19 pandemic. Minnesota Statute Section 13D.021 allows us to hold remote meetings during the pandemic because in-person meetings or a meeting conducted under Section 13D.02 is not practical or prudent because of a health pandemic or an emergency declared under Chapter 12. Over to you, Co-Chair Paul.
Thank you, Commissioner Harpstead. Welcome, everybody. Happy March. And as is the case in March, right? It's 40 degrees. No, it's snowing. Wait, it's going to be 50. All the above, right? In the same day almost. So great to see you all. Thank you for taking time to join us today. We've got a good agenda here. So today is our first meeting programmed by one of our vision committees. So excited to get to that. We're going to have a panel on health equity, some Q&A time, and some larger group discussion of kind of integrating some of those learnings into the roadmap. And then we'll also be taking time to break out into our individual subcommittees towards the end. So we'll be doing that every meeting, as you'll recall, and kind of doing some of our individual group work. Before we get started, though, I'm going to turn it over to my co-chair, Mr. Ettinger, for a few comments.
Well, thanks, Paul. I wanted to let everyone know, if you hadn't seen it in the news, that I filed to run last Thursday as a Democrat for the open congressional seat in southern Minnesota. This is a seat that was formerly held by Governor Walz, and it's where I've lived for almost 30 years. It's quite an interesting process, a whirlwind set of 3 different primaries and general elections in 2 slightly different districts, but we're going to give it a whirl and see how the process goes. I intend to continue to serve as co-chair of our council with Paul. I have cleared this with council for the state, and they have confirmed that, first of all, that the council work will be done before anyone's elected to any position. So it wouldn't be like I would ever be a sitting official and then still doing this. And then secondly, their caution had been that we need to be clear that I'm not to politicize anything related to our council. So for example, I can't let's start having lots of listening sessions down in the congressional district where I'm running, that kind of thing. So if any of you have any concern as we go forward here through the end of June that you're uncomfortable about anything because of my role, please bring it up to Paul. Please bring it up to the commissioners. That's clearly is not my object, is to create any problems for anyone here. But I did want to let you know.
Great. Thanks, Jeff. Appreciate you sharing that. And appreciate you checking in with council and the governor as well. So, okay, let's see. I think
Paul, if people aren't seeing it, Jeff, you should see their congratulations all around. So I think there was a few claps and a few applauses, but I'll bring the humanity out of the chat channel and at least just to interrupt to express it. Sorry, Paul.
Thank you. I'll take a look.
Appreciate that. All right. So I'm not sure who I'm turning it over to, but I think so this vision group, I think, is a combination of Talea, Commissioner Harpstead. Is Penny on this group as well?
Yes.
Yep. And
I am. I'm in travel mode, Paul, but I'm listening in and trying to catch as much as I can.
Great. Thank you. So I'm going to turn it over to you all to introduce our speakers and to guide us through the session.
Very good. Well, thank you all. We're excited to be here today and offer up some of the thoughts that we have and some of the suggestions you've made for people you'd like to hear from in regard to equity. The first speaker we have is Ellie Garrett from the Department of Human Services Population Health Team, who works with our Dr. Nate Chomolo, our medical director, on a study that was just released called Building Racial Equity into the Walls of Medicaid. We call it the BREW report for short in the department. And someone else from the council recommended Dr. Chomolo's recently released reports, and he is traveling himself on vacation this week. And so we're so thrilled that Ellie could be here as a member of the team to present the report. And after that, we'll move on to the next speaker. So Ellie, if you're prepared to share, or is someone going to share your slides, and you can go ahead and present.
I have them right here and ready to go. Let me just get into slideshow mode here. So I assume you can all see the slides in the correct mode?
Yes.
Okay, great. Well, it is my my delight to be here on behalf of our fearless leader, Dr. Nate Chomolo. I'm very honored to do so, and I'm actually going to be joined by our health equity liaison, Diego Diaz Rivero, toward the end of my talk here. The title of this report is Building Racial Equity into the Walls of Minnesota Medicaid, and or BREW for short. And the first focus that we have taken is on US-born Black Minnesotans. So as we do this work, it's important to consider the many legacies of violence, displacement, migration, and settlement that bring us here together today on this topic. And indeed, we must also honor the fact that the lands on which each of us is working and living in Minnesota and in our nation are in fact lands that were taken from the people who first lived here. Any work on health disparities is grounded in the work of others. We stand on many shoulders. Indeed, Dr. Martin Luther King Jr. noted that of all the forms of inequality, injustice in health is the most shocking and the most inhuman. Harvard science historian more recently noted, Evelyn Hammonds, noted a very clear and direct reflection on the legacy of our healthcare system when she said that there has never been any period in American history where the health of Blacks was equal to that of whites. Disparity is built into the system. So, as I said at the outset, the first focus of this work is on Black Minnesotans, and more specifically on US-born Black Minnesotans. As depicted in the circular arrows on the right, US-born Black people are predominantly descended from individuals and communities that were subjected to chattel slavery, to Jim Crow segregation, mass incarceration, police violence. They live in disadvantaged neighborhoods disproportionately, experience less wealth and less opportunity, all of which has been shown to lead to chronic intergenerational stress. And that chronic stress and these features of structural racism directly contribute to that racial health disparities we see today. And the legacy in particular of chattel slavery and Jim Crow segregation is distinct to US-born Black people in this country. While all racially minoritized communities in Minnesota experience health disparities in various chronic conditions, US-born Black Minnesotans notably have among the worst outcomes. And they are disproportionately represented within the programs of that DHS operates. So to really understand how our investments in, and also on the flip side, cuts in Minnesota's public healthcare programs impact health, we have to understand the people that we serve. And so the University of Minnesota's SHADAC group provided these data that we're seeing. They're the most recent data available and from 2018. And you can see that within Minnesota's Medicaid program, we serve a disproportionate share of Black Minnesotans, of American Indian, Alaska Native Minnesotans, of Hispanic and Latino Minnesotans compared to the general population. This is even more notable when we're looking at kids. So 64% of Black and African American kids in Minnesota are served by public health care programs at DHS. So just to kind of wrap this up, why we're focusing specifically on Black Minnesotans is that we have some of the worst racial inequities in the country, that this leads to some of the worst racial health disparities. We're disproportionately serving Black Minnesotans within Minnesota Medicaid, and therefore simply in order to do our job, Minnesota Medicaid must focus on racial equity. And this slide, I know it's too busy, but I've got a colleague here today who can take questions about the data depicted here. This slide brings home the fact that within our programs, the health of people who, the health of US born Black people is disproportionately poorer than the health of more recent immigrant populations due to a very well understood effect that we've been seeing for many years in this country called the healthy immigrant effect. So we have an opportunity to lead with racial equity, and to do that, it is important to connect with the communities that we serve. So we did this work at the level of involvement, and we reached out to people that we serve. We reached out to community leaders to help inform this work. And we focused our efforts around 4 areas of conversation, around eligibility and enrollment, around access, around quality of the health care once it is accessed, and early opportunities, what we can do, especially for kids, to help improve the health of the people that we serve. Now, even though we did this in a very culturally specific way, none of these calls to action seek to create Medicaid funds that are racially exclusive. Rather, we have calls to action that really resonated with the communities we spoke with, and that in many cases are long overdue. The first one of these calls to action concerns eligibility, enrollment, and renewal, and it just recognizes the simple reality that people who live in poverty, people who live with disabilities, don't typically recover from disabilities or move out of poverty in short periods of time. And so implementing a 12-month continuous eligibility policy, especially for kids, and this is, I have to mention, in the governor's proposal, would really help us to reduce some of the churn that exists when people go on and off of Medicaid for no reason other than administrative hassle. Another call to action had to do with navigators. Everything about healthcare is complicated. I can't imagine how anybody navigates healthcare these days without the kind of expertise that everybody in this meeting probably has. I would imagine many of you are yourselves navigators for your family members. Providing navigators who don't have those resources within their families to help them understand the enrollment and renewal process, continuing to prioritize that as an activity is really, really important. It's also important that people have access to culturally relevant care. And that includes that our own lens within DHS is culturally relevant. And so one of the calls is for that internal look at DHS to invest in an internal structure that has a specific focus on US born Black Minnesotans. Another kind of internal focus that we really need to do, but we need a lot of help to do so, because in some cases it calls for legislative change and regulatory change at both state and the national levels, is to continue to prioritize how we understand the people that we serve, how we look at our own data. And there are many barriers to collecting good data about the people that we serve, and we have a lot of trust to build in order to collect those data, and it's very important that we do so that we can measure our work. And at this point, I'm going to turn this over to my colleague, Diego Diaz-Rivero, to sort of bring it home. He is a health equity specialist within the Medicaid program. Diego?
Thank you, Ellie. Good evening, everybody. We wanted to highlight as well that throughout this report, we were very intentional on how we engage with community leaders, community members throughout listening sessions and series that we did in the evenings. And throughout our conversations with community members and leaders, we really had a trend that kept coming back, and it was the need for rebuilding trust, and trust to, in general, state agencies and the government that was even widened throughout the COVID-19 pandemic. With that in mind, we felt the need to have a third call to action surrounded around engaging the communities and families of Medicaid services in a way that's intentional, but also process that's a longitudinal way of engagement and culturally specific focus. Therefore, in this call to action, we really hope that we are able to have a longitudinal approach to fund community conversations with U.S.-born Black Minnesotans on Medicaid by integrating community engagement, building that into routine decision-making for policies, budget decisions, or any other administrative activities in the case of the administration that we work for, healthcare administration, which should be informed by community members and their families receiving services. Along the lines of capturing the moment for change, we did want to recognize other factors that influence the lens and the focus of this report and our research, which will be an iterative process that we hope to do with other communities in the future. But we utilize the President Biden's COVID-19 Health Equity Task Force and their overarching priorities to inform a lot of the pieces of this report and our research methodology. For this reason, we just want to highlight 5 main levers highlighted in the task force. First, around investing in community-led solutions to address health equity, enforcing a data ecosystem that promotes equity-driven decision-making, increase accountability for health equity outcomes, invest in a representative healthcare workforce, and increase equitable access to quality healthcare for all. Lastly, to lead and coordinate implementation of COVID-19 health equity task forces, recommendations from a permanent health equity infrastructure. In our case, we hope to continue building this infrastructure in-house at DHS that would support the achievement of this leverage and also everything else outlined in the Brewer report. Again, in our spirit of capturing the moment for change, we do, as Ellie highlighted at the beginning, our plan is to have an iterative process where we will be conducting a very similar research methodology for other communities. So next we have Native and Indigenous Minnesotans report to focus on Medicaid, Hispanic and Latinx Minnesotans, Asian Pacific Islander, New Minnesotans who are part of the LGBTQIA community, Minnesotans living with disabilities, and Health Minnesotans and incarcerated Minnesotans. Here, there we go. In this last slide, we do want to give recognition to all of the partners that supported us throughout this research process and that were able to engage with us, not just the Brewer report co-authors, but also our community collaborators, as you can see on the slide. We had a big community conversation team, so shout out to our DHS colleagues who supported us throughout those community conversations. And we also had some wonderful technical assistance from our communications team to help give this report live and get it published. So Ellie, I don't know if you'd like to add anything else here.
No, I think we should probably turn it back to the moderator for the next panelist.
Thank you for
Unless
that.
there are questions right now. I'll leave it to the moderators.
I
preference?
think we'll wait to do questions until all three presenters go through their presentation materials. So I'm Talia Palmer. I'm the president of the Blended Foundation, and I am really happy to be the first folks presenting from the vision groups. I get to introduce Bridget Tuck with the University of Minnesota Extension Office out of Crookston, and she'll be doing a presentation on the disparities in American Indian healthcare spending in Northwest Minnesota. Bridget and I and Ronnie, I don't see Ronnie here, Bridget, but had worked together on an economic impact assessment at Northwest Indian Community Development Center, which is located in Bemidji, Minnesota. That's located in between Red Lake Nation, White Earth Nation, and the Leech Lake Band of Ojibwe. And that represents about half of the American Indian population in the state of Minnesota. And so I'm going to turn it over to Bridget to do this presentation. And thanks for agreeing to be here, Bridget.
Awesome. Thanks, Talia. I can't really see anybody with my screen on, so if there's anything, you just feel free to interrupt me. Good afternoon, everybody. As Talia mentioned, I'm Bridget Tuck. I'm joined by my colleague, Ronnie. She is on here. We work for the University of Minnesota and the Center in Extension for the Center for Community Vitality. So we work across the state of Minnesota with communities to help them make informed economic development decisions. And it's in this work that we crossed paths with Talia and really started a conversation and a partnership to look at what is the value of American Indian related healthcare spending in Northwest Minnesota. And we finished this and published this in 2020, just right before the pandemic hit. I really appreciated the comments from our previous speaker because I feel like a lot of what drove our work and some of the recommendations that will come out of our analysis really mirror and dovetail what they did. The focus a little bit was more on health inequities and outcomes in that previous work. We really focused more on the economic side of that. But I think the driver for our work really was, how can we improve outcomes? How can we introduce Native and American Indian cultures and values and traditions into healthcare to really help improve those outcomes? And then secondary, can we look at this from an economic perspective on how do we improve economic prosperity by helping American Indian owned businesses or workers capture some of that spending that's already happening within the economy? So we really kind of had a three-pronged approach to this. The first approach was to look at just the scope of this issue, right? To understand how much healthcare spending occurs in Northwest Minnesota, how does spending related to American Indian populations fit into that spending? What are some of the larger areas of healthcare in terms of subsectors in terms of spending? So it was really kind of defining the scope of that. The second thing that we did was really focus in on workforce. So this was really understanding who works in American Indian healthcare, what kind of jobs are there. We know there's an industry around healthcare, but what are the occupations within that? We looked at things like demographics in terms of gender, race, age. We looked at things in terms of salaries and training and education that is needed for those particular occupations. So we really dove deep into the workforce piece. And then the third piece we looked at was really more about supply chain development and really more on those business opportunities. What opportunities are there potentially for American Indian owned businesses to help become part of that healthcare supply chain? In particular, we focused in on three subsectors of healthcare. We looked at home healthcare, we looked at substance abuse and mental health care, and then we looked at nursing and community care. Our study scope did include spending related to American Indian populations from Medicare, Medicaid, and the American Indian Health Service. So it doesn't include anyone who would have private health insurance. We do have to give a big miigwech or thank you to DHS who did help provide some of this data for us. And then we did have a 7-county focus, which is on the slide here, so I won't read it. We did have a few key findings, and I have slides that kind of go into each of these, so I won't spend a lot of time on them. But I think the first two are kind of the big points. American Indian related healthcare spending is significant in the region, and there's absolutely room for diversification, not only from a racial perspective, but also gender and age. So looking at American Indian healthcare spending in 2017, which at the time when we were doing this was the most recent data, there was $1.3 billion worth of healthcare savings or healthcare spending in those 7 counties, making healthcare the 5th largest industry in the region, ahead of things like we might think of as leisure and hospitality as being a big industry. Healthcare had more spending than that. Spending related to American Indian populations was 20% of all healthcare spending. So 1 of every $5 spent on healthcare is related to American Indian populations in the region. So it is a significant piece of the healthcare picture in Northwest Minnesota. And we found that there really is room for diversification, and that's on a multiple levels. So in the current workforce, the data that we had from the census at the time showed that 13% of the total population in the 7 counties is identified as American Indian, but only 3% of the workforce in healthcare. The most diverse sector, if you will, within healthcare was home healthcare, which had about 20% of the population as American Indian. So there is some diversification in the industry. We also saw some issues around gender and age. So it is very much a female-dominated industry and also showing signs of getting older, which I think our next presenter will talk a little bit about the challenges around workforce. And then we also have some geographic concentration, which isn't unusual for healthcare. You can see the darker blue there are areas with higher numbers of jobs. So you see Bemidji, Grand Rapids, and Detroit Lakes. But if you look at some of the areas where we have higher concentrations of populations of American Indian, we can also see that those are places where there aren't as many jobs and perhaps points to some access issues as well. What we did then is we dived into each one of these sectors. So home health care, in the data that we looked at, is about $55 million worth of spending related to American Indian populations in the region. And then what we did is we took and we kind of broke out what are the major occupations within this. So you can see like home health aides, 36% of the workers are home health aides, 31% are personal care aides, and then you have some nursing as well. So what this tells us is that basically 2 out of every 3 jobs is an aide job, is a job as an aide. So I start to think about questions that might come to mind here are, do we have culturally appropriate training or have training and education that has a cultural lens for people that are working in that industry? This is the industry that has the highest concentration of people identifying as American Indian, but it's also some of the lowest wages. So what does that mean for economic prosperity? Are there opportunities for further to train and get higher salaries for some of those workers? The other thing as well is only 10% of payments for home health care go to local tribally affiliated providers. So again, there may be some opportunities here for American Indian owned businesses to move into that provider space and offer some of that as well. We also looked at substance abuse. This is a much smaller percentage of overall spending, about 14 million as compared to 55 million for the home health care. But it is something that is very much in demand. So the region already has 2 times as many counselors in this field as compared to an average region. So that's saying that there is a need for that and there are more people working in that field. About a quarter of all the employees are substance abuse and mental health counselors, but we don't have any colleges or universities in the region that are producing anyone with that degree. So again, that starts to raise questions around, we're recruiting people into Northwest Minnesota. What kind of experiences and cultural understanding do they bring into these positions? Are there opportunities to develop programs with a very specific focus on bringing those cultural traditional practices into the care? So kind of thinking about that perspective as well. And then finally, we looked at what are our opportunities to expand our supply chain. So here, this table shows for your average home health care business, how much money do they spend for every dollar that they spend, how much goes into different categories. So if you look at that first line there, 7 cents of every dollar they spend goes to real estate. Obviously, usually a business has to have brick and mortar, so that's not unusual. And then the right column shows an estimate of how much of that is supplied locally. So I have employment services circled here because for every dollar home health care services spend, they spend 3 cents on employment services, but only about a third of that is satisfied locally. So to me, this raises ideas around, can we bring in companies to help develop that can provide those employment services? I think we have examples of that across the state of Minnesota where we can do that and we can bring in some of those cultural and traditional practices into the healthcare provision. So this might be an opportunity. Now, if you look at the next column, we're probably not going to do a lot of pharmaceutical manufacturing in Northwest Minnesota. But if you look down, you can see things like management consulting services and office administration, some of that kind of back office work that maybe is an opportunity for growth and development. So again, questions that come into my mind as I look at this are, what kind of things are we doing to support our American Indian entrepreneurs and our small businesses? What can we do? We have data that kind of shows opportunities. What are the things that we might put into place to help get this from idea to actually action, to developing like a business plan and those kinds of things? So some thoughts that you might be thinking about in terms of what this data can tell us. And then finally, this chart just shows the skills that are needed. It shows it by quarter, so it's kind of trying to give you a sense of like what skills or kind of talents do we need over time, and what's kind of growing and maybe what's fading away. But you can see in healthcare, it continues to be around nursing, it continues to be around caregiving, it continues to be around home health care. And these are important things that we need to continue to invest in and be able to have workers in that sector. And again, I think our next speaker is really going to talk about that. So with that, I will turn it over to Ronnie to talk a little bit about some of the follow-up that's come out of this report and maybe provide some thoughts and ideas for future direction.
Thank you, Bridget. And hello to Leah and everybody on the council. In follow-up to publishing the report, we did share it back with the Northwest Indian Community Development Center, and they are currently working with Greater Bemidji Inc. to convene healthcare providers in the region to explore strategies to address employment inequities. And this would include about 45 in-region healthcare or home health providers and about 31 mental health and substance abuse providers that are located in that 7-county region. The report was also shared with the Northwest Private Industry Council and the Rural Minnesota Concentrated Employment Program, which are the local workforce investment boards, to help inform their workforce development planning. The University of Minnesota Crookston, Bemidji State University, and the University of Minnesota Duluth are exploring ways to partner with tribal colleges in the region to develop these healthcare career pipelines. And the philanthropic community up in this part of the state is also working to develop scholarship programs to support students pursuing rural healthcare professions. In addition to this, some policy and governance actions that we would like the council to consider would be targeted funding to support development of curricula to extend workforce pathways into K-12 classrooms, recruitment of private sector to develop what's called the KCO mentoring model between regional healthcare providers and K-12 schools. Also targeted funding for workforce development centers with existing healthcare skill certifications, as well as American Indian specific modification of the Inclusive Workforce Employer Program that is being piloted by the Northwest Minnesota Regional Workforce Alliance. And that's all I have for right now. But thank you very much. And are there any questions?
Again, we'll hold questions until all three of our presentations are finished. Thank you so much, chock full of information. I just want to add that Talia quoted this report at our last meeting, or maybe the one before that. I called her to say, tell me more. She sent me the report. And when it came our turn to present, we said, let's show it to everyone. And that's how you came to see it today. Someone can put my slides up now. Many of us have talked about coming out of the COVID pandemic and right into the workforce shortage pandemic and trying to deal with all the issues that have come with that. I think this dovetails pretty nicely with the last two presentations. And I want to show you a deck that I've been showing at legislative hearings this session that we call our Caring Professions Workforce. So next slide. Many of you have seen this before. You saw it here. It came out of our state demographer. And by the way, I also want to thank my colleagues at DEED and Nanoko Sato at the Council of Nonprofits for much of the data that's in this slide deck. You can see the entrance to our workforce over the last several decades over here on the left, and then you can see our entrance to the workforce over the next several decades to the right of this bar chart and how dramatically it decreases. Next slide. The caring professions are those frontline workers we've applauded throughout the pandemic. This is a fairly broad definition that includes nursing homes, assisted living, group homes for people with disabilities, behavioral health services, home care services, childcare, and healthcare. Together, all told, they represent 15% of the entire Minnesota workforce, a higher percentage than other states. DHS likes to say in our literature that we support 1.7 million Minnesotans in some way every year, which would mean that 15% of the Minnesota workforce serves 30% of the Minnesota population. Next slide. The average wage in the caring professions is about 30% below the average Minnesota wage, while the average Minnesota wage has risen 4.3% over the past year as employers compete for workers. My colleagues at DEED would like me to point out that there's a wide range within the caring profession. So the higher level nursing employees make a lot more than the people at the bottom. But if the entire group added together averages 30% below the average Minnesota wage, you can imagine how the lowest wage categories in this group factor in. And while all of Minnesota will suffer from a workforce shortage over the next 4 decades, the prevailing wage in this sector makes it particularly vulnerable. It's also an equity issue. So taking 2 categories of workers, childcare workers and nursing assistants, you can see the percent who are BIPOC, the very high percent that are female, and 19 to 27% actually receive our medical assistance benefits in the state, and 7% of the one category, 21% of the other are also on SNAP food benefits, probably because they make 30% less than the average Minnesota wage. Next slide. Also true that the white American post-World War II population was the first on the history of the planet to send its elders, people with disabilities, and family members with behavioral health issues to live with 24/7 staff because it could afford to. And even if we could afford it going forward, we won't be able to staff 24/7 congregate care for so much of our population any more than other countries can. Developments like Amazon delivery, grocery pharmacy delivery, Uber transportation make it more and more possible for people to remain in their own homes for as long as they need or want to. Next slide. So we will need new models, and the independence package that passed in last year's session with the Health and Human Services bill to support home care is the sort of investment we need. Still, it will take years for new models to be established, and this sector needs a smooth ramp down, not a cliff. The McKinsey report, you may recall from the phase 1 reports of the Council on Economic Expansion, said that automation and home delivery reduced the need for retail sales, administrative, and production jobs. The fastest growing sector will be the caring professions with their required social skills that cannot be automated. Next slide. Here you can simply see the teal blue wedge at about 2 o'clock on this chart is the healthcare and social assistance workforce and their high level of recent job vacancies. Next slide. So bills passed last year. We increased the PCA rate framework so that by June of this year, PCAs will be making $15 an hour. It seemed like a lot when it passed last year, and suddenly this year doesn't seem like so much. The CCAP rate increase that passed last year, there was an early rate increase for people who serve folks with disabilities, etc. Next slide. Between the federal government resources, the American Rescue Plan, and the governor's resources that were available to him between sessions, there were several funding mechanisms that were made available for this sector. You can see those. Next slide. Those were for nursing facilities. The next slide is for other providers, a total of another $250 million to source these providers. And the final slide comes from the governor's budget proposal that you've already seen. Of course, the supplemental budget is coming out next week, but you can see here a workforce incentive fund for the caring professions, a healthcare workforce revitalization plan, and additional supports for childcare for $670 million. And that was, I think that's about, oh, there is more. I did say to the legislature, I think all the proposals being discussed this session are the beginning of a discussion we'll have for years to come, as the fewer entrants to the workforce will be with us for decades. And I do appreciate that our Health and Human Service legislators understand these issues and also have bills into the session to discuss, and eager to continue in dialogue with the providers of these services to find innovations and workforce retention strategies that work. And that is the last slide. So Talia, I think you were going to lead our Q&A. Talia, you're on mute.
Of course, I'm on mute.
Yep.
So we've gotten a lot of information here in a very short window of time, and given the ideas that have been shared here today, what is one strategy or change that you think would best support economic expansion in the next 5 years? And I think that question is open for the panelists.
Well, Talia, I think there was a theme here throughout all three presentations. I really appreciated how well they all dovetailed together, because I think there was a theme here around providing opportunities to bring that lens from your own culture, your background, regardless of where it is, into healthcare, and really what are the opportunities to do that, because I think we get better healthcare outcomes.
And this is Ellie Garrett. I work at DHS, and I am reminded of, I used to teach health policy, and something that I used to share with my students was when Minnesota Care first started, I believe it was a commissioner of revenue back in the early days who observed that, wow, this is the first program I've ever seen that actually results in people getting off of other forms of public assistance, being able to return to the workforce. I think there's just such an inextricable link between health and the ability to thrive in all aspects of life, including work, that anything we can do to reduce health disparities will have a positive impact on the workforce that is in Minnesota.
One thing I wanted to point out is you can see that the governor has invested a lot of money into childcare in Minnesota. A disproportionate amount of our federal general funding went to childcare support in Minnesota. And if you think about childcare as the workforce behind the workforce, you can see that if we have good childcare, then the parents of those children can go to work serving older adults and people with disabilities, so their family members can go to work doing all the other stuff that the Economic Expansion Council has been talking about since last fall. And so these workforces are all intertwined and all necessary in order to enable the 20 to 65-year-olds to get to work and expand our economy.
I would just say that making those funds clearly available and very easy to get access to. What we find is that a lot of times there are funds out there and either people aren't aware of those funds, or the complications to actually get the use of those funds are so hard that they're a deterrent. And so they have to be easily accessible, and they have to be widely known in order for people to take advantage of it. I do love the wage increase piece. I think we should always be taking a look at that livable wage portion, especially in the healthcare space, because there are so many people that are employed there. And the admission that we do live in a very high tax state. And that, you know, the cost of living is something that has grown significantly. So, you know, like you said, you know, the $15 sounded really good, but you know what we found is that we're having to go back and take another look at what that looks like in today's environment. But, you know, immediately when you think about, you know, just the state tax and where it sits, and then you think about, you know, the property tax and where it sits, and you think about the housing market costs and where it sits, those things start to really eat away at what we would consider to be a living wage. So I think a continual look at that is going to be critical.
One of the comments that was made in one of the presentations was how post-secondary options are available, or what types of trainings and certifications people have access to. And that we know in, you know, rural communities and especially in Native communities, relocating for education is not something people opt to do. And so how do we invest in our post-secondary outstate universities, community colleges, and tribal colleges to make sure that these trainings are deployed and that they're accessible, to have the certifications that pass through the threshold of the billing requirements that are laid out for Medicaid and Medicare? And I really appreciate your comments, Brett. You know, my interest in this comes from applied knowledge, personal lived experience in my family, as well as being a nonprofit administrator doing community development work in a region where we were able to see. I appreciated Ellie's point of the navigator and the person who actually signs the person up for healthcare benefits has to be really well funded. A lot of people are experiencing like high levels of homelessness in outstate Minnesota, where something that, you know, we take for granted, like people don't have their birth certificate or forms of ID. And so they'll have to go back and forth and find reliable transportation just to be able to start to fill out that application. And then they're sent on a chase to get their social security card, or they have to go to the county to get a birth certificate and somebody has to give them $26, and they have to wait for that purchase order to go through, and they have to fill out all the paperwork, and that it's an incredibly it's full of barriers and challenges that a lot of people don't necessarily understand if they're not privy to human-centered design and the space where traditional or conventional economics meets healthcare economics. So I really appreciated what Ellie had to say about that navigator piece. I had ran and set up 2 navigator systems in northern Minnesota. Both did not fund full-time positions. It was really difficult to find someone willing to work for $19 an hour, 3/4 time, with no benefits to help other people who are underemployed get benefits. And so we put someone right next to the threshold of being on the other side of that desk, and we're not really incentivizing engagement in the healthcare system in that way. I wanted to also ask, and we've sort of fleshed out some of the questions that were posed for this, but how specifically do the panelists see that the council could help build this work into our roadmap for the future economy of Minnesota? So I'll say that in a more humane way. What would you recommend that this council carry forward to engineer for impact that benefits healthcare, addresses health inequity, and advances a more robust, inclusive economic infrastructure for Minnesota?
So, Leah, what I was going to actually say to that was the fact that I think that we're looking at the surplus as an activation point, but actually putting it into a permanent budget line item and incorporating that into the economic development and growth strategies as part of a policy, I think would be extremely helpful. And I just truly believe that if there's a way for us to help I'll just say the front lines and the people that are most affected in this healthcare space through a ongoing effort and not a one-time shot in the arm, I think that's what really creates long-term viability of really creating some momentum around this. That's where I would think we could start.
Talia, this is Ronnie. I would suggest that the council really consider how they can help facilitate relationship building between the healthcare sector and the educational institutions that are serving them. This would reach all the way down through K through 12 education and through post-secondary education. But I think the critical point is like in talking with some of the workforce development professionals up here, like the career pathways specialists at the high schools are strapped. They have to pay for their own certifications to, educate these students in like STEM pathways. And so if there's any way that their programs can be supported or augmented with state funding, I think that would be a huge boon to like alleviating some of the pinch points in that pathway development system. Thank you.
Other comments, suggestions, recommendations? One of the things that I heard in the presentation was also the business startup and seed money for businesses to be locally owned and operated. So I saw some of that. I saw supply chain language around the economics of the healthcare system that I think is really important to look at for impact. Tracy, you're pretty quiet. You usually have some things to share.
Well, I'm just thinking about first off, root cause of low wages for healthcare workers and in the caring professions. I'm not sure. I don't really know what is the root cause, and in manufacturing, everything's about root cause when you're trying to solve the problem. The other thing that I was thinking of, and this is based on an episode of Krista Tippett's On Being that I was listening to a couple of weeks ago, but there was a woman presenting, she was from Louisiana, and she's a lawyer who works in environmental activities as well as a broad range of things. But one of the things that she said at the end of her conversation that has really struck me, and she was speaking about caring professions and, kind of indicating that a lot of her time has been thinking about the intersection of race and where that fits in healthcare. But she said, when it comes to the caring professions and their suppressed wages and their inability to earn enough really to thrive in the economy, that she's wondering if it's more of devaluation of the feminine over the masculine, or putting the feminine below the masculine, and that there's a difference in value there. And I think there's something to be thought about there as well. I mean, I understand fully that race plays a role, but I do think that there are many caring professions, including childcare and other things, where women are the predominant workers, where we're talking about these suppressed wages that don't allow people to thrive. So that's all I'd say.
And I would say, amen, sister. This is women's work, has been for centuries. And while you can see that up to 50% of the caring professions are people of color, almost 100% are women.
Neil, when you're looking at this through your lens, what are some of the thoughts that come to your mind?
Unfortunately, I'm in the quiet period for the Federal Reserve around our meetings. That's why I'm in Washington, D.C. right now. So unfortunately, I have to be in listen mode. But this has been a great discussion, and I've got lots of ideas percolating that I'll be happy to share once I come out of the quiet period. Thank you.
Well, Talia, as your other favorite neighborhood economist, I guess my perspective on the wage thing is always I'm looking at it from the math equation, right? And so especially my daughter is a CNA in a little nursing home near our hometown. And, they only get so much reimbursement per patient, right? So they only are able to take in so much money, and then how do you make the math work? You can't spend more than you take in. So I think the same with childcare, right? Like as a parent, I can only afford to pay my childcare provider so much. My childcare provider can only take so many children under the state and federal regulations. So there's a tension there between how much I can afford versus what she needs to get paid. So I think that's somewhat factored. I always think that factors into some of these discussions around wages and healthcare, particularly when you get into like that nursing and home healthcare side, where it is maybe set by someone outside of your control, right?
I just want to add regarding childcare that, as you all heard, other countries pay for childcare for their citizens through a public benefit. And I mentioned the investments we're looking at making in our childcare assistance program. That's a tiny part of the childcare industry in Minnesota. The vast majority of childcare payments are made by parents out of their own wages. And so when you have to make your own wage a certain amount to pay your bills, and then you have to pay for your childcare out of your wages, the math is really difficult to make work, except for very high-paying jobs.
And what implications do you think that the current situation we have is going to have on the quality of care that we're going to provide older Minnesotans in the next 3 to 5 years?
I think it was our last meeting where the state demographer was in, and she showed a line chart of the growth in the workforce, which was flat, and the growth in the aging population, which was far from flat. And there's the problem right there.
And then we had Brenda present a while ago, and I'm always thinking about some of the information that she provides and talking about the value we have of our healthcare workers and how are we attracting younger folks into this field when we have sort of tapped out the morale of the field during the pandemic. And so what kind of additional surge do we need to put into the system to reattract and stabilize the existing system and prepare for that aging population?
Yeah, and I'll just say in greater Minnesota, again, where I live, it's kind of like the manufacturing has this high demand, wages are rising, right? Like every day there's a new sign at the manufacturing plant that they can pay $1 more an hour than they did yesterday. So there's a lot of churn in like that same level of skill, right? Like why go to work for the nursing home at $15 an hour when you can make 22 with the same skill, kind of demand at the manufacturer. So there's a lot of turnover in our healthcare, like especially again, those aid kind of positions. There's tons of turnover there. And I do think there's something here around mental health. I know my daughter comes home crying, once a week because it is really difficult work. Like she's in the memory care unit and it's tough, and her heart breaks every time she goes to work for the people that are struggling in her care. So I think there's something there too, Talia, not to be overlooked, that this is really difficult work and they get burned out too.
I would agree with that, Bridget. I know when I'm driving around up here next to, like 30 minutes away from Grand Forks, I hear about nursing positions opening up in Grand Forks with a $4,000 sign-on bonus. And I'm like, that's where all of our healthcare workers are going from the region, is over to North Dakota. And it breaks my heart. But if those larger employers can offer that, then, how are we going to keep our workers in state?
We're going to turn our attention here now briefly to a conversation among council members about how all of what you've seen today fits into our work as a council. But before our speakers leave, I wonder, Ellie, perhaps you could start if you have anything else you would hope that we learned from you today.
Oh, goodness. I actually hope nothing I said was news. So I just so appreciate the efforts of all of you, and thank you for the opportunity to present.
And Bridget or Ronnie, anything final comment about what you would hope we'd heard today from you?
Oh, I'll join Ellie in sharing my appreciation for the ability to showcase our work, and hopefully it'll help inform your decisions.
I echo Bridget's sentiments.
Well, thank you very much for joining us today. We certainly appreciate these really stellar presentations made with really impeccable data. So thank you. Thank you so much for sharing them with us.
Bye-bye.
Our planning team has asked us to turn our attention for a few moments now to, as a council itself, as you're thinking about the roadmap, where does this take us next? I just wanted to share a couple things from our subcommittee. Our subcommittee had a lot of stuff in our corner of the roadmap. It had health equity. It had workforce, and they wanted to be sure that behavioral health was included in healthcare, and a lot of comments about equity in general ended up in our corner of the roadmap. So there was a lot of stuff. We did think these three presentations dovetailed quite nicely, and several of you have said that. So that's what we chose to present today. We want you to know that we've also had a plan to meet with Sue Abderholden from NAMI, the mental health advocacy organization, so that we're sure to include behavioral health in our final report. But we'll be doing that offline, and decided to use today's meeting with the council to show you these three presentations. So would like to just ask you now in general what impressions you have from these presentations you heard today. What did you learn today that you didn't know? What new insights do these bring to you as you think about our phase 2 report?
Well, I do know that I wasn't aware of the stats, the statistics associated with our healthcare space, and it was, for me, it was eye-opening. I have to admit, I mean, my mother was a healthcare worker, and so I often went up to visit her at the hospital that she worked at, and so I did see a lot of women in that space and in the childcare space. But I had no idea the numbers were that skewed, and some of it I believe is maybe even a trust thing, especially when it comes to childcare. For some reason, I feel a lot better when you feel like someone maternal is taking care of your child. I don't know if that's a mental thing, but it's just one of those things. But I didn't know that minorities made up, the BIPOC community made up such a large portion of the healthcare field, or that the healthcare field paid so much lower than the average wage. So I was that was a learning experience for me. But it also makes me wonder about why we're just now kind of tracking all of that. It seems like a huge opportunity to move forward with with a focus on something that could really move the needle.
Perhaps one of those learnings from the pandemic, huh? That put these workers on the front page.
No doubt. No doubt at all. Yeah.
Jody, I was going to just share, and again, great presentations and good data. The disparities data just, again, reinforcing what I feel like we've been hearing for so long. And the gender cut on it is obviously is very powerful. And part of, and this is kind of also relates to my small groups trying to get our arms around some of these bigger problems. And again, I'm kind of increasingly across many of these issues, I'm coming to the market issue. So we're trying, and this was touched on by several folks, and Tracy, you captured this well as well. We're trying to pay, with childcare, we're trying to pay for a public good through a private market. And it doesn't, and again, I think back, my kids are now college age, but my goodness, for that first 5, 6, 7 years, 2 kids, I mean, we were making some serious calculations. Our kids were in full-time daycare. right? Serious calculations on, is this worth it? And what does this cost? And what is the, how much money do we need to make this worth it, right? For either myself or my wife, who was a very accomplished full-time worker, right? So I'm struck by the systems issue and the systems question. We're trying to pay for a public good through a private market. And somewhat similarly, although very different, in healthcare, I'm sitting on a healthcare board and just starting to learn about the economics of healthcare, right? And the cost structures. I mean, just way crazy economics, right? And revenues set by agreements, right? Especially with Medicare, Medicaid, and revenues kind of driving that, and care decisions kind of being tied to. So again, I don't know if that's a case of of a public good, healthcare being paid for by a combination of a governmentally regulated and or private pay insurance-based system. But my real point here is that these systems don't work, right, for the delivery of what it is that we need, or what we say we want, right, for our communities, for our elders, for our kids. So I'm struggling with that larger, how is this system working? And when I think about the charge of this task force, of this council, which is to look at the larger systems issues and figure out what needs to change in order to really drive economic growth for the long run. Those are some of the bigger questions that I'm focused on.
I really appreciated that, Paul. I think we hear in a lot of different sectors, we hear about these challenges, but it's so much, healthcare is such a good place to look, because you've got labor issues, then you've got this idea of, and the care professions in general, you've got the fact that you can price out, we could say that the market ought to solve the problem on childcare. But the second it gets too expensive, then we're going to serve the childcare with a member of the household who's going to come out of the workforce. And it really does emphasize that I think the system has bigger problems than we can solve with just, I think the Commissioner Harpsted might have mentioned, the small potatoes of some of these programs that we're talking about that are, incentives or, other things just don't seem like they're going to get us there. Without a bigger move on healthcare and childcare. So I really like that point. I had one other thought that has just been on my mind is we're going to have to, I don't think that the labor solution is going to get us as far as we want. And I'm wondering about not just the system, but even technology and other approaches that might open up solutions that go beyond just figuring out the worker problem. And I know when you talk about that in healthcare, you open up a big can of worms. I'm married to a physician, and when she sees an alternative provider that's not a doctor that might be lower cost show up, she has immediate concerns about the quality of healthcare dropping. And I get that, but we are one of the most inefficient economies in the world at providing healthcare and leveraging the healthcare dollar. And I think that's true in some ways of childcare too. I just think having this fragmented system creates a lot of inefficiency in how we deliver it. We're going to have to get more efficient, even as we want to solve the labor problem. I don't think you can just do one or the other. I think you have to do both.
Yeah, I completely agree. I think really well said, both of you. I think that the market failures here are really, really striking in both childcare and in healthcare, and in a lot of these long-term care facility issues too. I think that, one of the things that we have to balance here and try to figure out is what can you do to fix systems like paid family medical leave or childcare or healthcare and still have the economy move. And one of the opportunities that we have in this section of our work is to give ideas to both business and government and community leaders. And I think for all of us, for all these areas, thinking about creatively, what role does business play here? What role does government play here? What role does the nonprofit sector play here? as kind of the audiences of our final recommendations is going to help us, because I think it's going to take more than just government to fix some of these gaps, given the competitive pressures that are there. But bring it back to this overall issue of talent. If we're the kind of state where those market failures don't exist, or at least don't exist as pressingly as they do in other states, that can also attract workers to want to come be a part of this economy. So it's a differentiator for us too, if we can make serious headway.
I was in a meeting last week with the small group that I'm a participant in, and I'm going to repeat something that these are not my words, but I found them to be very valuable. And the member of our group who gave them isn't speaking today, but we were talking about government subsidies. And if you think of an area like agriculture, where, you know, a decision has been made to subsidize agriculture to a certain degree so that farms can survive, farmers can make a more sustainable, consistent living and pay for what they have going on. But we want consumers to be able to pay a reasonable price for food. And if, you know, if that's one of the premises or the premise for a farm subsidy, you could, I mean, I can in my mind envision how that could apply to other things, which is the discussion that we were having. It could apply to childcare. We want to provide childcare workers, the industry, with good paying wages so that they're taking care of our children, giving them an opportunity to become the great workers of the future and succeed in their education. But we want the consumer who needs to go to work to be able to pay a reasonable amount of money for that. So I just throw that out there because I thought that that was an intriguing idea. And I think it's worth thinking about areas of the economy where we do subsidize things and we feel perfectly comfortable doing it, and how else we might utilize something like that in the future. So.
I'm wondering if any of the economists that are on the panel, or if anybody would speak to the relationship between lesser dependency on the fossil fuel industry and the decrease in living wages, and sort of the intersection of that. Because Medicaid is directly related to poverty. And as, like, for example, on the range, as mining decreases, and we see people leaving the range over the last 30 or 40 years, the people who have stayed become low income, and Medicaid becomes the economic driver in the region. So how are we tipping back that scale to have a diversified economy that isn't dependent on fossil fuels, to transition, that just transition forward into the future? Thought about you, Steve, when I was watching the State of the Union address and Intel ended up in Ohio, and I was going to call you and be like, Steve, why didn't you get that for all of us?
Yeah, well, it's a great point. You and I have talked about this, and I'm sure we'll talk more. You know, we have this energy transition office at DEED that we're just getting started up, and this week we could share we've hired a new director. I think we're announcing it on Wednesday to focus on just this, because you need plans in place. Obviously, what's happening in the Ukraine right now and Russia just takes this issue and elevates it all the further. So we're tracking that really closely, and I think, you know, communities like some of those on the range who know the exact date at which that coal plant's going to shut down need to start planning now for the next set of jobs. And we've got to figure out how to balance environmental concerns and some of the mining development that's needed to get us in a stronger position. I mean, you look at batteries, right? And the batteries required to run electric cars. A lot of the metals that you can use to make those batteries come from mines that are in Michigan and Minnesota. So how do you get that right? You know, how do you make sure that we can be part of fueling the green revolution with you know, fusion cells and the battery supply chain, while also preserving the boundary wires? I mean, we're all seeing these issues play out, but these are the kinds of things that we're grappling with inside of government, and that I know this group's going to help us think more deeply about, because there's not easy answers to it, but it gets more important by the day.
Other insights, things you learned today that you didn't know that could contribute to our phase 2 report.
I'm curious how we link what we heard today on that. I was really intrigued by that educational mismatch that not only are there certain jobs that are really, it's difficult to even find the right educational resource, but on top of that, it can be a regional resource. And so that, so here you have somebody, maybe you have somebody who's actually motivated and wants to be in the industry, but there's these impediments to even be able to go get that education. So as a council, how do we address that? I mean, we kind of have these various priority areas and issue areas that, but do we need to be bringing somebody in on the education side to be understanding, well, why aren't certain programs offered certain places, or is there another way to kind of push that forward?
Jeff, I'll speak to the. Oh, sorry, Paul. Go ahead.
Well, just very quickly, I wrote a note down to myself. So on the healthcare spending, I'm trying to remember the presenter's name, but they were talking about how do we create pipelines, right, into different positions in healthcare, and she was talking about connecting to local workforce investment boards, connecting to the local community college, thinking differently about training and more of a kind of what really it's career pathways. It's part of what PPL does here in the Twin Cities, right? In other industries, but how do we create those career pathways that do help us build and develop talent, usually in a shorter term, very industry specific, really cost efficient way, actually, and quickly gets people into the pipelines. And healthcare is an industry where we do a ton of that, actually. And I don't know how much of that happens in greater Minnesota or in those communities, but it's a really good point, Jeff. And I think it might be one of those systems pieces. I know in our workforce, phase 1 workforce articles, we were talking about some of that, upskilling, reskilling, career pathways, building the pipeline into jobs where they are growing, and also getting a living wage. So I think that I was touching on some of the same things that I heard you mention there. Sorry, Steve.
No, well said. And I'll brag on you for a second. PPL does some of the best work in Minnesota on this front with pathways. It's really impressive. And I think we try to get other grantees that we work with to look to PPL's model. I just popped a link in the chat that's related to what both Jeff and Paul were just saying here, which is an updated list and a tool that we have focused on the occupations that are most in demand in Minnesota. And it's a complex answer to the question of, how does Minnesota State determine its class offerings, or, what workforce training programs get momentum? And oftentimes it has more to do with, individual efforts maybe than data. But this data will give you a sense for where the most need is. And Commissioner Harpstead is exactly right. 40,000 of the job vacancies in Minnesota right now are in healthcare. That's the highest number of any industry in the state. So you'll see when you look at this tool, a lot of healthcare jobs there in that occupation and demand pathway. So we try to get this out to people so they know what's there, and also to educators to know what to offer. But it's a complex system. So I think this group's thinking on that will help.
One of the things.
Excuse me, Celia, go ahead.
Well, I was just going to comment that Steve, one of the things that I've learned in this group is thinking about how do we recruit people to Minnesota, and that there's a proposal to put sort of a targeted marketing approach to that. And are we considering anything like that for healthcare and raising the value of healthcare and getting people sort of seeing the value of that to do the recruitment? And then I also don't want to lose the fact that to share that, again, to hear that we don't have enough post-secondary counselors inside of our high schools, that we're 50th in the country for these career pathways. And oftentimes in some of the schools that have these major disparities that they deal with, we're not designed to truly meet them in that scale of the way that we fund those career counselors. And if that doesn't change, I don't see how those pipelines change for somebody to sit down and help fill out scholarships and FAFSA and college applications, especially when you're a first generation student. And we need those people to be in the workforce.
I was just going to add that I've listened to and read about employers who are deciding that pipeline might just be their responsibility instead of thinking that all they do is hire employees. For example, in services for people with disabilities, which require only a high school education, could they hire people and use the time that they're working for them to allow them to go to school to get a certification to become a CNA, which they could go do over here while they continue their schooling to become a nurse or to get a degree and go do something else. But the employer that figures out how to offer people a chance to come in and do this work while giving them the time, perhaps the money, and the flexibility to go do other work might be able to fill some of these jobs. And so I'm hearing some creative solutions around that.
Yeah, we are too. A lot of interest on like college age students doing like ER part-time during the school and trying to fit it in around schedules. Just you're trying to look for where the available labor pools are, and I think younger people and sort of part-time and shift work like that can be part of the solution for sure. We hear a lot about that and are really trying to push that with our colleges.
Well, I think our subcommittee time is up now. I'm going to turn it back to, I think I'm to turn it to Liz to break us into subcommittees.
Okay, so to combat some of the technical issues we had last time, Nick sent an email, and we're going to be going just from here right into some subcommittee work time and individual meetings. So we're not going to come back to this large group afterwards. So I just want to have people know that if their subcommittee has some momentum, they can decide when they want to end, but we thought this would give people a little bit more flexibility and be more of a more of a technical benefit. So let us know if you don't have access or didn't see the email that Nick sent. It has all 5 subcommittee links, and just click on the one for your subcommittee. And if you don't remember your subcommittee, I put it up on the screen. So you can and it's also in the email. So with that, I think we can all leave this call, and then the facilitators can start their other meetings. So, and thanks, Carrie, for putting that in the chat.
So
Jeff, want to close out the meeting?
Yeah, and I don't have a lot to close out with, other than we'll meet again in a couple of weeks. I know several of the subcommittees are trying to find some outside time just to gather, to kind of do some of your work outside of the council meetings. If you're able to do that, great. Try and keep connected to your lead staff person. I think we are going to welcome, is it group number 3?
Yes, yeah. Holistic supports.
That will shape the next, and that is that the business expansion group?
It's the holistic supports group.
Holistic supports, okay. We'll kind of program the bulk of the next meeting. We'll still have time to break out in small groups as well. So thanks, Jody, and who else was our, Talea and Penny for your work pulling today's session together. So fabulous. All right. See you later.